I was treating with a subthreshold micropulse laser since 20 years, but in the last approximately 1.5 years or 2 years, I am doing it with nebulas. Then it's important to say that when you treat with a subthreshold laser, it means a wide range of different treatments. Subthreshold means you are not going to see the impact at the moment where you are doing, but could be a delayed impact, 1 week, 1 month, or 3 months. If you treat close to the fluence of photocoagulation in the upper part of the therapeutic window, you are near to the photocoagulation, and in the lower part of the therapeutic window, you are near the photobiomodulation treatment. Then I'm going to present you my experience in photobiomodulation parameters, lower fluence and lower parameters, not in the higher part of the therapeutic window, in the lower part of the therapeutic window. This is a laser intervention study in patients suffering from diabetic macular edema with a follow-up of 12 months. We finally included 14 patients and 22 items in the study. The mean visual acuity is 0.6 in decimal. You can see here the pre-treatment image with an important macular edema, fovea filtering, and then after treatment, we can see a clearly improvement and 12 months follow-up. Classifying our cohort of patients between the weight of the edema, 22% of the patients have grade 1, 64% of the patients have grade 2, moderate edema, and 9% have severe edema. I included in these patients with grade 1 or grade 2 edemas. Depends on the type of edema, we can divide in focal or and diffuse, but cystinoid could be a part of the focal edema, one subtype of focal edema, but I would separate because it's important for the results. Then you can see here the preoperative image with a lot of exudation in the macula with very active microaneurysms, and in the post-treatment 1 year follow-up, here we can see less exudation and the macula is better. All the scars with the laser, I think today we are able to avoid these scars. No rescue anti-VEGF injection was given. I repeat the laser in case of worsening or no effect or stability in 14 patients. Half of the patients, more than half of the patients needs retreatment. I have to retreat 3 times each case. And the mean distance between treatment was 4 months, maybe. Here you can see another example of typical patient coming to my office with some exudates in the internal plexiform and external plexiform, close to the center of the fovea. I treat the patient, in 1 year follow-up, I see a clear improvement. A little fluid persists, but you can tolerate some little degree of fluid with this kind of treatments. I'm using a laser Navilas platform with 577 wire length. I use classical parameters with a duty cycle 5%. It means 100 microsecond on. Each pulse is 100 microsecond with on, and 1900 microsecond off. The total envelope of the train of pulses duration is 200 milliseconds. The spot size is 200 microns, and I use fixed settings because I'm going in the down part of the therapeutic window. I'm doing photobiomodulation in my cases, then I don't need titration. I use fixed parameters with 400 milliwatts. The resulting fluence is 13 joules per square centimeter. I do not titration approach. This is a subthreshold diode micropulse laser-like plan. I made a central confluent network within the 5 millimeters of the central fovea with no spacing between the impacts. When you make a net like this, you need to be sure that you are not going to harm the retina of the patient. Then it's important to go in photobiomodulation parameters. in the lower part of the therapeutic window. Right? You have to be sure that you are there. With the yellow wavelength, you can be sure because you can make a titration in micropulse mode, and you can see if you go up with the power, then you can see the impacts in micropulse mode. With the 810 platforms, it's impossible to see the impacts in micropulse mode. You never know where you are located in the therapeutic window. This is the main difference to know where you are. In my experience, only 36% of the patients improve their retinal thickness without a statistically significant result. This platform enables us to make a perfect education, reproducibility between operators, repeatability, repeat the same controlled change, only changing one parameter, you can repeat the same treatment. Make true confluencing with non-overlapping is important. In my personal valoration, analyzing globally retinal thickness, visual acuity, microperimetry, improved their baseline status in almost 35% of the patients. Here you can see a microperimetry of one patient treated. Look, in a year follow-up, is improving, clearly improving the microperimetry, the sensitivity of the retina is improving. The visual acuity changed in 50% of the patient, gain more than 5 letters, make this result statistically significant. Visual acuity gain and grade of edema seems to be correlated. The mean gain in decimal scale is correlated with the grade of the edema. Patient with grade 1 gain 0.2 decimal. With grade 2 wins less. It means that the treatment is important, the degree and the location of the edema for the result of the treatment. Here you can see a clear improvement. Pre-treatment, you are going to see hard exudates and lip exudates and some flame hemorrhage. And post-treatment, the patient is better. The patient is effective in a small and perifoveal low-grade diabetic macular edema. The treatment is only effective in moderate peri and parafoveal diabetic macular edema. Look the pre-image in front. It's an erythra, the erythra image. Look the red one. Here you can see a very active microaneurysm, and in the post-operatory you can see a clear improvement. But still, the exudation is still, because it is a photobiomodulation, not a photocoagulation. We have to tolerate. Then the treatment is less effective in very active microaneurysms. In this case, it's a very active microaneurysms. I treat the case, the patient are better, but the fluid under the retina still, the heart exudate still, and the active microaneurysms is still leaking. In conclusion, yellow navigated subthreshold diode micropulse treatment could be a valid treatment alternative for case of low-grade diabetic macular edema. It could be interest treatment of choice in mild edemas when intravitreal injections are controversial. It's not indicated in case of very active microaneurysms due to the high rate of retreatment, and the absence of OCT structural improvement could lead to a loss of trust between the patient and the doctor. Then we need to look for a more effective treatment in this case. Thank you so much.